discuss another antibiotic that in the Netherlands we don't use at all. We have a few case reports, but I felt that this drug, we discussed it, I think 6 months ago at the Antibiotic Steering Committee group in Rotterdam, Rotterdam Medical Center, where I come from, the Netherlands. And I thought it would be a nice complementary discussion to have on this drug as well. So briefly, there's an overview of this presentation. I will tell you a little bit about the background of this drug, pharmacology, microbiology, and also the indications and contraindications. So we have 3 cases in the Netherlands in which we treated these patients with Temocillin, but I really had to dig in deep to find them. I will briefly discuss also the costs, mostly in euros, and also give an overview of the literature, the most relevant literature. So obviously, resistant gram-negatives are a major challenge to treat. And Temocillin was mentioned that could potentially be used as a carbapenem-sparing regime. The drug is a derivative of ticarcillin, and it was developed in 1981, so it exists for a long time already. At that time, it wasn't used because of the small spectrum. At that time, that was considered a major disadvantage. However, it is used in Belgium, Luxembourg, UK, and France. And actually for a long time already. And in the Netherlands, it's only registered for 1 indication, which doesn't happen that frequently, and that's cystic fibrosis patients with a bacterial infection that require medication. It's a semi-synthetic beta-lactam antibiotic, and up above right, I shown the 2 structural formulas. And specifically, this group, the alpha-methoxy group, makes this drug so special because the hydrolysis by class A and B beta-lactamases, so the expanded spectrum beta-lactamases and the MC producers, is prohibited or inhibited. The half-time of this drug is about 5 hours when given intravenously, and it's cleared mostly by renal clearance, and between 72 to 82% is non-metabolized, which makes it potentially good drug for urinary tract infections. It's water soluble, and there's protein binding of approximately 80%. Like already mentioned, there are high concentrations in urine, bile, and peritoneal fluid. It's low in cerebrospinal fluid, and the minimum time unbound Temocillin above MIC for an appropriate antimicrobial effect is about 40 to 50%. My apologies if there are sometimes some Dutch words in between, it's also my autocorrect. The dosing is 2 grams every 8 to 12 hours. And so far, I couldn't find any cases in the literature on overdosing, and it's safe to use up to 8 grams. And also, I found that there's actually some studies performed also by studies that they looked if it can be cleared by hemodialysis, and that's also possible. So the spectrum is gram-negatives. There's no activity against gram-positive non-fermenters or anaerobes. In the Netherlands, we use cephalosporins primarily in treatment for urinary tract infections, combined with gentamicin primarily. So we wondered if this organism, could also be treated with Temocillin, for instance, if the microorganism is not susceptible to cephalosporins, because otherwise your alternative would be a carbapenem. But this is data from the Erasmus Medical Center. They register from blood isolates what the resistance is, and every 5 years they do a report. I will highlight the most important figure. So if you would treat a urinary tract infection, just as an example, you see there's a so our primary antibiotic would be cefuroxime combined with gentamicin. and you see there's a resistance 15 to 20% in E. coli coming from blood cultures, and the gentamicin also shows a 6 to 8% resistance. And we have about a 7 to 13% ESBL rate in E. coli from blood isolates. For Klebsiella pneumoniae, it's more or less comparable, and ESBL in this it's my reference there. And ESBLs they're in between 8 to 22%. Again, this is coming from blood isolates. The problem with Temocillin, although it has been around for a long time, there is, to my surprise actually, there's not a lot known about this drug at all. In the UCOS, which we use to look at breakpoints, there's nothing known. I did look up the British breakpoints, the ESAC. There they do have cutoffs, especially for urinary tract infections and bloodstream infections. We sometimes also look at the epidemiologic cutoffs, ECOPs, but formally you cannot use these to guide your therapy, of course, because this is data on MICs for wild types for antibiotic, and those wild types are worldwide, so it's not regionally bound. And so for Temocillin from the ESAC, there was a breakpoint known specifically for urinary tract infections, and it's set at 32. These are the ECOS, and there you see, if you can more or less look at this data and interpret it, it would be a breakpoint of about 8 to 16. If you look at the Burkholderia carbapenem, for the E. coli, that would be also around 8 to 16. And for an Enterobacterales, MC producer, it's also relatively low in my opinion. So the question is, can you use this in a situation where you have a chloroquine-resistant microorganism and a urinary tract infection, intra-abdominal infection, or Burkholderia eradication, if you wish to be carbapenem-sparing? So there are some contraindications. If you have a reduced renal function, you need a dose adjustment. But basically, if you have a GFR lower than 10, you can still treat it with 500 milligrams 24 hourly. And considering pregnant women or in the situation of breastfeeding, there is not a lot of data known, but in my opinion, that's with a lot of drugs. This data is lacking. So I looked at this experience we have in the Erasmus Medical Center. So we have one patient that was supposed to be treated with Temocillin because that patient, 28-year-old, had cystic fibrosis, and there was a situation where they wanted to eradicate this Burkholderia. However, at discharge, I found out that this patient was still changed to carbapenem. That was more because of logistic reasons. So in the Netherlands, we send people home and then we do outpatient antibiotic therapy a lot. But that insurer wouldn't cover it in this case. There was also a 7-year-old baby with early postnatal complications, a urosepsis due to kidney stones, that needed a very specialized operation that was only performed in Amsterdam. But until the operation, which was planned 2 weeks later, we had to make a choice if the patient was going to be treated with meropenem the whole time. But the patient was already treated on meropenem for a week already, and we decided to switch it to Temocillin, and that worked out actually pretty well. So more about the logistic difficulties that you have to deal with. It's of course in a Dutch situation. You need an official medical justification, a note from the microbiology department, and you need an import license from the pharmacy department. And of course, there's these things you have to deal with when you're treating patients in an outpatient setting. I tried to look up the South African prices, and I went to the pharmacist yesterday, and I found out that meropenem here is cheaper than in the Netherlands. It's here for 1 gram, it's 75 rands. I found out, and that's the governmental price. If you look at the Dutch situation, there's €2, which is 200. Yes, so it's about 50 rands, and Temocillin is about 10 times more expensive. So that's obviously a major disadvantage. So in conclusion, should we get it? For instance, in the Netherlands, at that time we made a discussion, and we found that from a stewardship point of view, it would be a big advantage. And also because it had no side effects, and the indications right now are expanding. In most of the studies, non-inferiority has been proven, superiority has not been proven yet. But the biggest problem, obviously, is the price and a lot of administration. So briefly, so what is the literature and why don't we know that much about Temocillin? There is actually a Lennert paper from 2021 that describes cefotaxib versus Temocillin for urinary tract infections. And those patients got this drug intravenously, and the endpoints were, I think, well, Nicola has also studied the urinary tract infections. They always look at clinical improvements, but it's more or less fever, flank pain. But also they look at microbiologic medication. And what they also did in this study, which I found really interestingly, is if a patient would grow a resistance microorganism from the gut flora. So in this study, they found that in the Temocillin group, a blood culture was slightly more positive, and there was slightly more recurrence of urinary tract infections, but otherwise it was comparable. Both were non-significant. Temocillin was considered non-inferior. I don't know how they found it was even superior, but I would not interpret this as superior, but non-inferior, I can agree with that. They mentioned that it was potentially superior because of the early reduction in flank pain, for instance. Temocillin reduced the colonization of cephalosporin-resistant microorganisms. I think that's a very nice result that they found. But they did find somewhat more often considered the Temocillin group, but the numbers are low. So the meaning is somewhat unclear. The strengths and weaknesses of the study is that they also had a exclusion rate of antibiotic use if you had used antibiotics 1 month prior to the study. And there was a remarkable slow inclusion rate. I found out, if you look at the additional papers, that most of the patients were admitted at emergency room, of course. And the emergency doctors usually didn't comply well with studies. But they already gave antibiotics before the patient could be included in the study. But these are the endpoints. I think this represents well what I've just mentioned as well. And they also looked at the bacteriological response. And well, the clear things that favor Temocillin is especially so there's disturbance in the gut microbiota. And late bacteriological response. So there have been 2 studies written in clinicaltrials.gov. So that's the Temocillin versus carbapenem or imipenem study, which compares also these drugs in urinary tract infections. It's called the Temocarb study. I just looked it up. I sent the study to Nicola on Thursday, but I found out yesterday evening that there are still already some results in, and they show that the clinical cure rate in the carbapenem group was a little bit higher, with 98% versus 94% in the Temocillin group. But that was considered non-significant, the p-value of 0.207. So the other study that's coming up is the Astarte study. It started in December 2020, and the results are still pending. So these are my take-home messages. Temocillin could potentially prove as an alternative to meropenem. Few side effects, not influenced by ESBL or MSC-resistant mechanisms. It's used for bacterial eradication, UTI, and potentially more. Evidence is remarkably absent, although it's been around for a long time. There are no breakpoints. However, we do have epidemiological cutoffs, and it's been shown to be non-inferior, and the major disadvantage, obviously, will be the costs, 10 times higher than.
Well, I'm starting to take questions in Dutch. So, before you, so I'm interested in talk. Thank you very much. It's very nice of you. Just to come back to you on the Dutch experience, why do you use cefuroxime plus gentamicin for in combination therapy for urinary tract infection?
I think you can go other ways, but we have different centers using different
Why do you need the combination, particularly when your actual sensitivity rates are really very good for both, particularly for gentamicin?
For gentamicin, it is. So gentamicin is given once. That's primarily because you want to take out potentially ESBLs and Enterobacterales. But so you give it once, and then you continue with cefuroxime, which is our primary choice, which is, I think, called defendable. And then after a period of 24 hours, you would have your blood cultures. And then if you would need to continue, for instance, on gentamicin, then usually we wouldn't continue gentamicin, but we would switch, for instance, to carbapenem. So I think this is that's the reason why I always understood. And we accept a resistance rate of up to 10% based on our hospital data. So if we have a resistance of 15% to cefuroxime, there's a need to add something else, in this case, gentamicin.
No, so we're talking about complicated urinary tract infections and pyelonephritis, not cystitis. The cystitis you wouldn't give the gentamicin. Although I'm asking, because I mean in South Africa, in primary healthcare, you can give a stat dose of gentamicin as the treatment. And so, again, you could make a case of just using the aminoglycoside as your first choice if you know your surveillance data in patients coming into your hospital with complicated urinary tract infection. I don't know what the application sensitivity is. It might be better for the Klebsiella, but I mean that would reduce your cefuroxime. But the other,
can I just follow up? I mean, are you using cefuroxime orally?
No.
So the other question is around it's obviously not a drug that's used very often, and even drugs that even penicillin the world needs faces massive stockouts because there's no active pharmaceutical ingredient being made, so they just isn't there. I mean, who's making this drug, if anybody, and where do you get it from in the Netherlands?
We usually call our pharmacist, and it's produced in Belgium. It's called Negaban, and that's where we get it from. I tried to look up if there's an import license also here in South Africa, but I talked to the pharmacist and she didn't even know about this drug. She looked it up, but there's no import license at all for this drug.
No, sure not. Sorry, I don't know the question.
Active against ESBLs and MCs, right? And it reminds me of like debates that we had about the use of Temocillin and Temocillin, actually, using this role as a carbapenem-sparing agent. And I guess the comparative advantage of this antibiotic Temocillin and Temocillin is that it's kind of more narrow spectrum. We wouldn't want to kind of preserve it for pseudomonas. But I just saw kind of similarity.
It's an activism against pseudomonas.
No. It's not active.
No, it's inactive.
Yeah.
Yes,
Yeah, so
I think there are some studies performed where they see in vitro spikes.
yeah, it makes it a safer alternative.
Yeah,
right, because,
yeah.
yeah, you don't have the CEOs. Colleagues, what are your thoughts?
So the only experience we have is one patient, and that even defaulted. So, so I would assume IV because that's what I found to be indicated for.
You nebulize it.
I did not look that up.
I mean, cystic fibrosis is quite an effective way of giving drugs more.
Yeah, no, yeah, many of the centers they also important. I think you do that here as well.
So does this drug, does antibiotic come up in the microbiology and also South African micro?
And just, do you know this, is it quite easy to do some specific mutation? I mean, I know there's only ECOX, but that one.
Exactly for that reason, it's somewhat challenging. I discussed this also with the microbiology department in the Netherlands, and they said they had the same, like, thing they needed to produce actually these new discs. Actually, because otherwise it would be microdilution, of course. That's of course possible, but they didn't have a lot of experience with microdilution for Temocillin, so they needed to set that up as well. Yeah.
Doesn't your biotech report it?
You need a special sensitive card.
So just a question. So for in the Netherlands, you've suggested that this is a, it costs too much, hence it's not featuring as in your program. What do you know what the cost effectiveness point in the Netherlands for a molecule to be rendered?
So I think in Europe, but also in the US, probably they use qualies. I looked it up also for Temocillin because I was interested in this question as well.
Yeah.
And there's one study that looked at the cost effectiveness of Temocillin compared to, for instance, the carbapenem, and they found out that the quality adjusted life year. So like there's in Europe and the US, there's this. I think in Europe it's 50,000 euros or dollars. It's the same at this point. So $50,000 would be agreeable per year as a cost. And I think Temocillin came out on 38,000 if you also take in like treatment of all patients, like all the patients that usually use the carbapenem and switch them to Temocillin, but also like the chances that you would get resistance from it. Still, Temocillin would cost $38,000 a year more than carbapenem, but that was considered a positive result because it's lower than 50,000.
I think we need to wrap up, just out of interest. I mean, do you use ertapenem in the Netherlands or not? Do you use ertapenem in the Netherlands?
Not that frequently, actually.
It's actually much more expensive than meropenem in Europe. And obviously the problem is the pseudomonal the spectrum. But one of the reasons we use ertapenem, we managed to get it cheaper, which is bizarre because it's usually the other way around. It's not that we're getting it more